Welcome to the Apollo Social Science Podcast, where we explore the borderlands between healthcare and social science. In each episode, we're going to speak to a researcher who's working in this space to hear a bit about 3 books or thinkers or ideas that have influenced them in their research journey. So today I'm really glad to be welcoming Professor Deborah Swinglehurst, who's the leader of the Apollo Social Science group and is also my PhD supervisor. And we're going to hear about 3 big ideas that have influenced her research journey and journey as a practitioner as well so far. Deborah, would you mind just telling us about one thing that you're currently working on, just to give us a bit of a flavour of the sort of work that you do?
Yes, so I've recently been involved in a number of projects exploring polypharmacy. Polypharmacy refers to the use of multiple medicines by one person, and I've been running several projects in this area. One of the main projects is called Apollo MM, where I've been researching the practices of polypharmacy across general practice, community pharmacy and in patients' homes. That's included following the lives of older people prescribed 10 or more items of medication and seeing and learning about how they integrate polypharmacy into their daily lives and what challenges it presents for them.
So today we're going to hear about 3 ideas that have been really instrumental in your journey as a clinician and as a researcher, and who's asking these sort of questions and working in these sort of creative ways. And I wonder if we could start with your first book, which is a book by Trisha Greenhalgh, How to Read a Paper. Could you tell us a bit about sort of where you were in your career when you came across this book, what it meant for you, and why you've chosen it today?
Sure. So I came across this book as a GP registrar. In fact, I think it was published the very year that I was in my transition between a hospital doctor, junior hospital doctor, and a GP. And I read this book out of interest and because I wanted to learn how to read a paper, I suppose. And I found it to be a really compelling book. Evidence-based medicine was a new thing. And evidence-based medicine, as it was originally described by David Sackett, is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of patients. And that held really intuitive appeal to me and seemed to make a great deal of common sense. And so I read How to Read a Paper in order to build some skills and confidence in understanding how to work with patients, to ensure that what I was doing was based on good science, if you like. And I became a great enthusiast for evidence-based medicine, and really it was that interest that led me into academia, because my first post as an academic involved building a question answering service for GPs and practice nurses, where they were able to submit their questions from their practice for which they'd like to understand the evidence, and my role was to find the relevant literature, search for it, find it, do the critical appraisal and provide a brief summary to these practitioners to assist them in their work. And that's a job that I took on essentially very soon after qualifying as a GP. So it was really that reading that book that got me into my first academic post. I have since become somewhat critical of the way that evidence-based medicine has been implemented in practice, but at that time I found it a really exciting and compelling notion that I could really make use of in my everyday practice, especially in the context that I was soon to move from having a trainer next door to working independently as a GP, and really realising I did need some skills and tools in understanding how to work out what to do.
Yes, and just kind of asking on that kind of journey you've gone on since that time, because I guess I really like finding this out about you and this as one of your important books, because now I picture you as someone who, for me, has helped me to kind of challenge some of the, some of the assumptions that's made about evidence-based medicine and where maybe some of its blind spots are, at least in how it's used now. And so I guess I'm interested to know, what are those concerns that you'd now have about the evidence-based movement? But also, it sounds like it's not that you've kind of said it's all kind of useless or it's all completely wrong. So this book's still a really important part of your journey. So tell me a bit about how you view it now.
Yeah. So one of the things that was interesting about this role that I had, where I was providing evidence-based answers, I put that in quotes really, answers to the GP's questions, was, first of all, I did come to realise that there were some fairly major gaps in the evidence when it came to actually implementing the evidence such as it is or was in a general practice context. So I did discover that many of the answers that I provided to practitioners were quite hedged and were there was a considerable amount of interpretation needed to actually implement what was in the science in the clinic space. And of course, a lot of the patients that we see in general practice would be excluded from the original trials and so on. So there were some distinctive gaps in the evidence. The other thing that was quite interesting about that project was that I was conducting that work at Imperial College School of Medicine in London, but living in Ipswich and practicing as a GP in Ipswich. And in the project, I had to work really quite hard to encourage our participants to pose questions to the service. So they wanted to be engaged, and there I was available, but I had to work quite hard to get them to submit questions to me. While this was happening in Ipswich, where I was working as a GP, everybody knew that I had this other job in London where I was delivering this service to local in London GPs, and they thought, that sounds really good. I'm a bit stuck with something. I'll just see if I can send Deborah a question and see if she can maybe help me with that. So whilst I was having this challenge in London about getting questions in, suddenly in Ipswich there was this thing going on, and I guess that made me realise that when it comes to the evidence, it doesn't stand alone in any way. It needs interpreting, and actually, because I was well known in the Ipswich area as a practicing GP, I was familiar and maybe trusted by colleagues and so on. There was a different level of engagement, but of course I didn't really have time to be doing all that work in Ipswich. But it was an interesting. It gave me some interesting things to think about in terms of where does evidence sit in our practice and what else needs to be in place to make use of it. I mean, in terms, I've now forgotten what your question was.
No, you are half answered it. So it's about kind of where that journey was taking you, and I guess how now, as you've kind of gone on, I guess a number of steps where you've further critiqued some of those gaps and just just pointed out that it really isn't set up to ask or answer some of the kind of key questions that exist. Sure. How you now look at the evidence-based medicine movement and where its role is in your view now.
I mean, I'm sure, like most GPs, I make use of guidelines, evidence and so on, and I do find them genuinely very useful. But obviously they need to be integrated within a wider scope of practice, and there are limitations about the evidence and so on. I think the other critique really around evidence-based medicine is the way that it's been tied up with pay for performance and initiatives like the Quality and Outcomes Framework, where doctors are essentially paid for following particular guidelines, which comes with a distinct set of problems, there's one fundamental problem is the way that people are carved up into their separate diseases, and we start to have a very single disease focused approach to managing patients who often have multiple problems and therefore need to be managed with that in mind. So we could talk about this for a very long time, I'm sure, but there are some significant problems in how it's become integrated into health policy and the kind of behaviours that it can drive, I think.
Yes.
So I think the other thing is that at its inception, one of the key problems that evidence-based medicine was seeking to address was the problem that we were heavily dependent on experts whose opinions often varied, and so there was great variation in practice, and there was a desire to ensure that decision making is grounded in scientific evidence rather than just in the practices of a particular expert. But as time has moved on and the commitment to doing medicine by guideline has got stronger and stronger, what we find, of course, is that many of the national guidelines, a lot of the guidelines we have are indeed based, there are sections of them that are based very heavily on consensus opinions. So we feel like we've done a whole circle really, and actually that isn't a bad thing. The recognition that a consensus of expert opinions is a good form of evidence, but
yes.
but it's a shift in how it was conceptualized up front. And so we're now in this strange place where we've made a big shift towards a kind of protocol-driven approach to many things in medicine.
Yes.
There feels now that there's a protocol for everything almost, whilst and that doesn't work. That doesn't work in the complex arena of human beings experiencing multiple medical problems or even single medical problems, and the kind of shift towards a risk of slavishly following a set of protocols and guidelines is, I think, is a dangerous one.
Yes.
So I think that's a significant problem.
Yes. So
and as you said earlier, the evidence has to start somewhere, and actually much of what we're doing is in general practice in particular is seeing patients with an undifferentiated set of messy symptoms, many of which are not symptoms of disease or pathology, but are symptoms of something else, symptoms of distress, for example. And of course, most of our evidence starts with a diagnosis, or a well-defined problem.
Yes.
The kind of problem you can do research on, and that's just not a terribly good fit for much of the work that we do as GPs.
So I think that brings us really nicely to your second choice, which is a book with a beautiful title of The Mystery of General Practice by Iona Heath, which is, I think, from how I've heard you talk about this book before, is going to speak to some of these things. But again, do you mind just saying a bit about what this book meant to you at the time you read it, and some of the kind of key ideas from it that have stuck with you now?
Yeah, so this book was written in 1995. So again, it was quite a new publication at the point at which I was entering the field of general practice. And I read it, I think, having been a GP for a couple of years. And the significance for me was that it really presented to me an understanding of what you might call the essence or the nub of generalism, that it was perhaps better articulated there than in any other place that I'd read, because general practice or generalism is so often defined by what it isn't rather than what it is. And this book really helped me to understand more clearly, I think, what my role as a GP might be. So the shift from hospital medicine into general practice can be quite daunting. And much of my training as a medical student was around disease and pathology, and then the shift into general practice can be a shift into what feels like quite a strange place,
right.
Because we have to think very differently about the nature of our role, and the disease is not our focus. It's not our key focus. It's serving people with, as I said earlier, often a messy array of symptoms that arise out of living life. So I found, I've gone back to this text many times because I still think it's one of the clearest articulations of generalism that I have come across. And whilst it was written in 1995, I think it is just as relevant, if not more so, today.
And there's something that she says in it about interpreting stories, which I really liked. Have you got that quote? I've forgotten what it is exactly.
So the mystery of general practice, that there are three particular interrelated roles that Iona introduces around generalism and being a GP. One is the GP as witness to suffering. Which speaks to notions of being there, listening, not always being there to solve a problem or fix or cure or prescribe or any of those things, but being a witness to suffering. And perhaps identifying the role of the GP as someone who encounters much suffering and being a witness to that is important and is sometimes enough as well. So witness to suffering, and then interpreter of stories, and the next one, which we can come back to once we've discussed stories, is guardian at the interface between illness and disease, which we can come to. So interpreter of stories is the role that the GP has in helping patients to make sense of their suffering, and it places the consultation or the dialogue very much centre stage, and invites us to think about biography as well as biology. But that there is a distinct danger in medicine that we can get pulled towards focusing on biology, and the role of the GP as interpreter of stories is first of all an invitation to give the patient time to tell their story and to listen, but also offering opportunities for patients to rehearse their stories, perhaps over multiple encounters, and offering a space in which patients can hear themselves recounting their stories to another. And it perhaps shifts the notion of taking a history, which is what we all learn at medical school, taking a history to making a story. So there's something about supporting the patient, and this is another kind of witnessing role, really, witnessing and listening and supporting and helping patients to make sense of their illness and make sense of their suffering to the extent that is possible. So I found that a very powerful and helpful way of thinking about what I should be doing in the room.
Can I ask you about how that's really been one? How that's come into the way that you've approached research as well, because both of those two things, as those first two we started with as a witness to suffering and as an interpreter of stories, how has that played out in the way that you've approached your research?
So I'm a qualitative researcher, so I work a lot with words and meaning, and have used narrative methodologies in the design and conduct of interviews, and have also done research which involves recording consultations and paying attention to the dialogue in quite close detail, and looking at how the dialogue evolves within the consultation. So I've and I would say all of the research that I do as a qualitative researcher would sit within what's called an interpretive paradigm. So the acknowledgement that there is always interpretation in all that we do, and that meaning is something which is made. So as a qualitative researcher, that a distinctive recognition that I, as the researcher, I'm engaged in an interpretive process.
Yes.
Which sits very going back to the evidence-based medicine thing. This has been a journey. So
yes.
This is a very different paradigm
right.
that I'm now occupying as a qualitative researcher. So yeah, I hope that's helpful.
You. Yeah, and then you said the third point was then as a guardian between illness and disease?
So a guardian at the interface between illness and disease. So this is a kind of gatekeeping role, and people are generally quite familiar with the idea of a GP as the gatekeeper between primary and secondary care, the person who is able to make a referral to the hospital or the consultant. But perhaps even more important in the work that we do is doing the interpretive work, if you like, between illness and disease. So illness being all of the symptoms and suffering that people bring into the room, and our role in making sense of that with the patient, but we're diagnosticians as well. And so one of the role of guardian is essentially around protecting a patient from the over-enthusiastic or overzealous use of investigations, diagnostic labels, referrals, and so on. Because if we use those things over-enthusiastically and too willingly and get that wrong, and then there's a lovely line in her book, the over-enthusiastic interpretation of illness as disease leaves patients open to the dangers but not the benefits of scientific medicine.
Right.
So scientific medicine, be it blood tests, imaging, referrals to hospital, medication, all of these things can do a great amount of good, but they're all capable of doing harm. And so if for example, everybody that we see with a headache, if we investigate every headache as a potential brain tumour, then we expose a patient to all of the risks and potential harms of medicine, which includes anxiety, worry, exposure to tests and potentially drugs and other things. We expose them to the harms, but not the benefits, if you like. So it's just as important that we don't use these things in situations where we don't think they're going to do any good.
Right.
So that's I think a really critical role of the GP, and I think that's a role that's really hard to do well, especially in a society that is becoming, I think, increasingly unable to tolerate risk and uncertainty. But if we can, I think this is really hard to do well, but it's very important to do it well, because otherwise we can have a patient who's come in well, who goes out sick, which isn't really our role, it seems to me.
Yes.
So, our primary ethic is first do no harm, and so this is an interface where I think we have to really be very careful how we manage it. And I'm sure we don't all get this right all of the time, but as a kind of principle of practice or an ethos or a value, I think it's really important. So I found this at the time. I found this it was a way of thinking about my role, the guardian thing, that I hadn't really perhaps fully understood or hadn't quite got in some way. And that really changed, or did it change my practice? I wouldn't say it changed my practice, but it really changed my orientation to what I do, and I suspect it did change my practice. because that's been a really kind of influential way of thinking about my role.
And that's definitely played out in some of the research questions that you've been asking too.
It has. And as I said earlier, I've been doing some research on polypharmacy amongst older people, with a particular focus on patients prescribed 10 or more items of medication, which is a pragmatic marker for what's called higher risk prescribing. So it's a situation where we know that we may be exposing patients to unnecessary harm. That's not to say that's not sometimes, it is sometimes necessary for patients to be on a number of medications, so don't get me wrong, but we also know that over-prescribing for patients obviously places them at risk of drug interactions, falls, hospital admissions, and that there's a very solid amount of evidence that shows this. And so yes, it's played out in some of my interests in what we might broadly call medical overuse. Because these are really, these are really important moral questions. That the kind of balance between too little, just enough, and too much of all that we do is a really, it's very difficult to get that right. But it's really important that we strive to get it right.
It's kind of striking that at the start of your career as a general practitioner, you've sort of got these two books which seems to me like a bit of a call to the best of medical knowledge, to sort of get and use knowledge the best you can, but also a call to, I don't know if wisdom is the right word, but something that's not in the realm of just knowledge. So something that's, as you say, a value judgment, a sort of, it's calling forth a courage, perhaps. So something that's, it's at the level of values and of something that can't really be contained by the evidence-based medicine movement as a whole. Quite.
And courage is definitely a virtue in all things, but in general practice, where at the end of the day, many of the people that we see don't have will not benefit from a diagnostic label or a disease label. So being able to work well in the realm of patients who may have many symptoms but don't have a disease is really important.
Yes.
I ran a workshop with a colleague at a few years ago now, which we called cultivating the courage to avoid medical overuse.
Right.
So there is a virtue of courage involved in it.
So the third idea we're going to hear about is probably the one that people are least likely to have heard of, and it's someone who is from a different country in a different era, and a thinker, a writer called Bakhtin. And I'd like to ask a bit about, first of all, how you came across him, and secondly, what he has meant to you since that time.
Yes, so Bakhtin was a philosopher of language and a literary critic, a Russian literary critic. And his work originated in the early 20th century, but was only available in English translation in, I think, about the 1970s. And he spent some of his life in exile, so even the authorship of certain texts is a little bit unclear. Anyway, I came across Bakhtin when I was doing an Open University master's module on discourse analysis, and it was early on in my PhD, and that was a course that exposed me to what it turns out is a huge field of different approaches to studying language and interaction, and language in use perhaps is the best way of talking about it. So Bakhtin was one of the many scholars that I came across in that context, and I was doing my PhD on how I was exploring how electronic patient records, which were then still quite a new thing, how electronic patient records shape the organisation of care, but also, and quite particularly, how do they shape the consultation. And so I was looking around. I was video recording consultations and capturing the electronic record as it was used, the text, the shifting and dynamic text of the record as it was being used. And I was searching for a way of a set of theoretical tools that would speak to that work and help me to make sense of it. And I kept coming back to Bakhtin, and I started reading some of the original texts, which are quite difficult when you haven't read them before.
It doesn't surprise me, actually.
Quite difficult reads. But I just found myself coming back to Bakhtin, and so in fact I've used some of the ideas that Bakhtin introduced in a number of pieces of work since. So I've drawn on Bakhtin on a number of occasions, and one of the key things that there are a number of concepts that I draw on, but one of the key things that Bakhtin introduced as a notion is the concept of language as dialogical. And this was a really radical shift at that time in how language is understood. So it's a shift away from the idea that language is a set of codes that transmit or represent information towards the notion of language as being fundamentally dialogical, so that all spoken utterances must be understood in terms of how they respond to a previous utterance and how they anticipate the next utterance. And this could be in spoken language or indeed in written language. And the consequence of this is that the meaning of language kind of emerges in the interstices, in the space between the speaker and the listener. And this means that the context, even the context of an emerging conversation, the context is shifting all the time. And the specific meaning of language can only be understood by reference to the very particular context in which it's articulated.
Yes. Can I ask
is that clear? It took me ages to get my head around this when I started working with this notion. And at some level, the idea that an interaction is dialogue feels very common sense.
Sure.
But there's something about the work that the language is doing, and if a speaker says something, then it could mean many things.
Yes.
But at the moment at which you look at how the utterance is taken up by the other person, it takes on a particular meaning. Which you can then discern more clearly.
I think I get it, but if just to kind of put it in like a use case.
Yes.
Let's say I was interested in talking to someone who experiences a certain illness about their experience of that illness, and if I was going to use a frame of language that, I don't know what the opposite of dialogical is, but like you saying like symbolic or like that language just holds one meaning at all times, it's fairly set. Or if I was going to use this approach of kind of understanding it dialogically, how would that affect how I went about that sort of research?
Yeah. So one consequence is that if you're the interviewer and you have your interviewee, recognising your role as interviewer as part of the dialogue. So you're not simply mining data, if you like, you're not gathering a set of facts, but you are participating in an interaction. So recognising your role as a dialogical partner in the interview. But it's more than that, because it also means in the analysis of, say this becomes a transcript, it gets transcribed as a text and you're analysing it. It means that when you are analysing the text, you need to appreciate that the language is doing some work that is over and above its work as a sign, or it doesn't just represent reality. There's a sense in which reality is or social life is being created in the act of the interview. So that's one thing. But the other thing, and I've used this in some methods, you may actually not use you'd use a transcript, but you may also listen carefully to the interview numerous times. I need to explain another Bakhtinian concept to explain why this is. So it's Bakhtin's notion of voice, and Bakhtin speaks about us always becoming through the act of appropriating the voices of others and bringing to those voices our own evaluative accent. So he's not only saying that language doesn't simply represent particular things, but he's also saying that when we speak, there's something about who is doing the talking. And so when we speak in our language use, we are appropriating the voices of others. These might be other people, they might be voices of certain dogma or scientific truths or discourses, and his notion of becoming is that we, in our lives, we continue to appropriate the voices of others. So our language is multivocal.
Mm-hmm.
So in an interview, we've recently used something called the listening guide, which draws on Bakhtin in theory. And in analysing these interviews, we listened numerous times to the voice of the interviewee. It doesn't become just a transcript.
Right.
And in one of the phases of the listening guide, we're actually listening for what are called polyphonic voices, trying to identify different voices within the utterances.
Yeah. Can you
so it's quite complex.
Yeah.
But it makes what the really exciting thing about it for me is that it enables approaches that allow us to see the great potential of language for holding ambiguity, for example.
Right.
And I mean, language is an amazing resource that we draw on all the time in our daily lives. And it's very capable of being used flexibly and accommodating ambiguity and so on. And the Bakhtinian approaches stop us closing things down, but allow us to sort of sit with the messiness of this complexity, which is something that I'm keen to do.
Yes.
So not closing things down and putting people or ideas into boxes too readily, but sitting with that complexity. And I think Bakhtin introduces numerous concepts which allow us to do that. It's difficult. It means that the act of analysing data is more complex.
Yes.
But also, I think, more interesting.
Yeah. Wow. Well, one reflection and one question. And one is that this just feels like the antithesis of the sort of hardcore core of evidence-based medicine, like the idea that you must deeply tolerate ambiguity and perhaps I'm doing it disservice, but it feels like we've gone a long way from idea 1 to idea 3.
Yeah. Well, it has been a journey. And it has been quite a number of years. But it's certainly there has been a paradigm shift.
Yes.
But I would also say that these are not either or.
Right.
They can be both and.
Yes.
And so I think the real wisdom, if you like, certainly as a practitioner of medicine, but also in our research, is understanding that there's much to be gained from accommodating different ways of perceiving the world and doing the world, if you like. So I think we need all of these different ways of understanding, and whilst they may be at some level philosophically a bit incommensurable, being able to accommodate and draw on these different ways of viewing the world at different times is, I think, very valuable and important.
Yes.
Yeah.
Can I just ask one more Bakhtin question because I feel like it's such revolutionary stuff, but it's also very tricky to see, to spot it. And perhaps one thing just to bring out this multivocality idea, would you be able to give an example from your research in polypharmacy about where you might hear, rather than just hearing the voice of participant X, where actually as you listen back you might hear a couple of different voices coming out, or them trying to do different work in answer to a question?
So we recently published a paper in which we introduced the idea of the multimorbidity tightrope. And this was a piece of work where we analysed our biographical narrative interviews using the listening guide approach. And what we were able to draw attention to was the way in which our participants, older people who were taking lots of medicines and had lots of problems, how they were at one and the same time they appropriated what you might call the voice of medicine, with its metrics and its surveillance and its numbers for blood pressure and blood counts and so on. So our participants very readily accommodated that kind of language in their accounting of their lives. But also at the same time, in close analysis of the text, you can see their voices of resistance, if you like, the way in which they were living in a position of great precarity but great compromise, and so there's an appropriation of this medical voice, and they all had very good relationships with their health service providers and so on. So there's an accommodation of that, but within a context of them also wanting to actively resist many elements of that and just get on with living their lives.
Yes.
And that struggle, if you like, between the demands of the clinic and the demands of living their lives with many medical conditions was one that expanded. It wasn't just about their medicines, but it expanded into all the realms of their lives. So there were struggles around how the voice of independence, I want to be as independent as I can be, but I recognise that I am dependent in some ways. So how do I manage that struggle? Yes, I've got a friend that is willing to give me a lift to that place every week, but I don't want to be a bother to that person. So the ways in which you can see the language being used to accept and resist at the same time, if you like.
Yes, that's brilliant. Well, thank you so much, Deborah, for your time today. Thank you everyone for listening in. Please do follow links to any of the 3 ideas that we've heard Deborah talk about today through the show notes, and you can subscribe to the podcast through most major podcast platforms. We hope to have episodes out most months. And please do visit the Apollo Social Science website if you'd like to find out more about Deborah's work and of others in our group. See you next time.